Chapter 16 Acute Kidney Injuries. Renal dysfunction is a common problem in the critical care unit, and with nearly two-thirds of patients experiencing some degree of renal dysfunction. The most severe cases require renal replacement therapy and have a reported mortality of 50 to 60%. Looking at the basic anatomy and physiology, each kidney is divided into two regions, an outer region called the cortex and an inner region called the medulla. The kidneys receive approximately 20 to 25% of the cardiac output, which computes to 1,200 milliliters of blood per minute approximately. As the blood enters the kidney through the renal artery, it then travels through a series of arterial branches and reaches the glomerulus by way of different arterioles. Blood leaves the glomerulus through an efferent arteriole, efferent meaning to carry away from, which then divides into two extensive capillary networks called the peritubular capillaries and the vasa recta. The capillaries then rejoin to form venous branches, by which blood eventually exits the kidney and via the renal vein. At a normal glomerular filtration rate of 80 to 125, the kidneys produce approximately 180 liters a day of filtrate. As the filtrate passes through the various components of the nephron's tubules, 99% of this is reabsorbed into the peritubular capillaries. The reabsorption is the movement of substances from the filtrate back into the capillaries. A second process that occurs in the tubules is secretion, or the movement of substances from the peritubular capillaries into the tubular network. Various electrolytes are reabsorbed or secreted at numerous points along the tubules, thus helping to regulate the electrolyte composition of the internal environment. The kidneys also play a key role in acid-base balance, and they provide this in several different ways, from reabsorbing filtered bicarbonate, producing new bicarbonate, or excreting small amounts of hydrogen ions or acids buffered by the phosphates and ammonia. Kidneys also perform many other important functions, such as in the production of red blood cells through a hormone called erythropoietin. There can also be a reduction in the production of erythropoietin that causes a shortening of the life of red blood cells. In the case of severe anemia, this can develop in people with advanced kidney diseases. The kidneys also produce the active form of vitamin D known as calcitrol. Calcitrol is important for calcium and phosphate regulation, influencing calcium deposition in the bone as well as reabsorption within the GI tract. Quick quiz. The accumulation of nitrogenous wastes is referred to as A. Anuria, B. Azotemia, C. Oliguria, or D. Uremic syndrome. That answer in this case is going to be B. Azotemia. Acute kidney injury is defined as the sudden decline in kidney function, causing disturbances in fluid, electrolyte, and acid-base balances because of a loss in small solute clearance and decreased glomerular filtration rates. A cardinal feature of an acute kidney injury is going to be azotemia and oliguria. Azotemia, again referring to that increase in blood urea nitrogen, as well as the serum creatinine, while the oliguria is going to be defined as urine output of less than 0.5 milliliters per kilogram per hour. The etiology of an AKI is classified as either prerenal, postrenal, or intrarenal, with the classification depending on where the precipitating factors and where this injury is occurring. Prerenal would be any condition that would trigger hypotension, such as low blood pressure, tachycardia, bleeding, or dehydration. While intrarenal would be any condition that would cause direct renal injury, such as inflammatory illnesses, polycystic disease, renal ischemia, or rhabdomyolysis. And finally, postrenal would be any obstruction, such as prostate diseases or kidney stones, that would stop the flow out of the kidney. Conditions that result in AKI by interfering with renal perfusion. These are the prerenal. Most prerenal causes of AKI are related to intravascular volume depletion, decreased output, renal vasoconstriction, or even pharmacological agents that impair autoregulation in the glomerular filtration rate. These conditions reduce the glomerular perfusion and the GFR, in which case the kidneys are hypoperfused. Conditions that produce AKI by directly acting on a functioning kidney tissue, either the glomerulus or the renal tubules, these are classified as intrarenal. The most common intrarenal conditions being active tubular necrosis. Acute kidney injury resulting from an obstruction of the flow of urine is classified as postrenal or obstructive renal injury. With postrenal conditions, increased intratubular pressure results in a decrease in the GFR and abnormal nephron function. The presence of hydronephosis or renal ultrasound or post-void residual volume greater than 100 milliliters is suggestive of postrenal obstruction. To summarize, pre-renal is going to be the decreased blood supply, renal is going to be failure of nephrons, and post-renal obstruction of outflow. What solution would be a priority intervention to decrease the risk of AKI in a patient with the following vital signs? A temperature of 39 degrees Celsius, a blood pressure of 92 over 40, a heart rate of 122, and a respiratory rate of 26. Would that be A, diuretic administration, B, fluid administration, C, antipyretic administration, or D, oxygen administration? And that answer is going to be B, fluid administration, to treat the hypotension as well as the associated possible infections. For a clinical judgment, describe the patient assessment findings anticipated in the three phases of an AKI: the initiation phase, the oliguric phase, or the recovery diuretic phase. The initiation phase is the period that elapses from the occurrence of the precipitating event to the beginning of the change in urine output. This phase spans several hours to 2 days, during which time the normal renal processes begin to deteriorate, but actual intrinsic renal damage has not yet occurred. The patient is unable to compensate for the diminished renal function and exhibits clinical signs and symptoms that reflect the chemical imbalances. Keep in mind, renal dysfunction is potentially reversible during the initiation phase. During the maintenance phase, intrinsic renal damage is established, and the GFR stabilizes at approximately 5 to 10 milliliters per minute. Urine volume is usually at its lowest point during the maintenance phase. However, patients may be non-oliguric with urine outputs greater than 400 milliliters in 24 hours. This phase usually lasts 8 to 14 days, but it may last up to 11 months. The longer a patient remains in this stage, the slower the recovery will be and the greater the chance of permanent renal damage. And finally, the recovery phase, or the return to tubular function. This phase is the period during which the renal tissue recovers and repairs itself. A gradual increase in urine output and an improvement in laboratory values should occur, though some patients may experience diuresis during this phase. With early and aggressive use of dialytic therapy, many patients are maintained in a relatively dry or volume depleted state and do not have large post-diuresis. Recovery could unfortunately take as long as 4 to 6 months, however. Other risk factors associated with an AKI would be things like an advanced age, morbid obesity, or pregnancy. Renal-related symptoms provide valuable clues to assist in focusing the assessment. For example, things like dysuria, frequency, incontinence, nocturia, or hematuria could be indicative of a urinary tract infection. The history also provides clues about medical conditions that predispose the patient to an AKI. Things like diabetes, hypertension, immunological diseases, or any hereditary disorders such as polycystic disease. The presentation may also vary. Patients with kidney injury from pre-renal causes may be hypotensive and tachycardic as a result of the volume deficits. Patients may hyperventilate as the lungs attempt to compensate for the metabolic acidosis is often also seen in AKIs. Body temperature may also be decreased as a result of the antipyretic effects of the uremic toxins. The patient's general appearance is assessed for signs of uremia or retention of the nitrogen substances normally excreted by the kidneys. This would manifest as things like malaise, fatigue, disorientation, or drowsiness. The skin is assessed for color, texture, bruising, petechiae, and edema, and the patient's hydration status is also carefully assessed. Current and admission body weight, as well as intake and output information, are evaluated. Skin turgor, mucous membranes, breath sounds, the presence of edema, neck vein distension, and even vital signs are also all key indicators of fluid balance. An oliguric patient with weight loss, tachycardia, hypotension, dry mucous membranes, flat neck veins, and poor skin and turgor may be volume depleted. As far as laboratory tests go, creatinine is a byproduct of muscle metabolism and is produced at a relatively constant rate. When kidney function is decreased, creatinine levels rise rapidly, indicating a decline in function or a decrease in the GFR. Serial changes in serum creatinine and urine output are markers for the identification of an AKI. However, the value of serum creatinine in predicting kidney cell injury is limited because the serum creatinine levels are influenced by everything from muscle mass, age, sex, race, protein catabolic rate, hydration status, and medications. BUN and creatinine levels are very helpful in diagnosis, though. The creatinine tends to be more specific to kidney injury itself, and the entire ratio will be evaluated. Urine creatinine clearance provides an estimate of GFR. In the absence of a 24-hour collection, GFR is estimated using standard formulas. Historically, the measurement of creatinine clearance over 24 hours has been considered a reliable estimate. Timed urine collections are cumbersome. They are susceptible to multiple errors in collection. To measure creatinine clearance accurately, a precise collection procedure is required. That being one, that the bladder is emptied and the exact time recorded. So you have the patient void, and that would be right there when you start the 24-hour urine. Next, all urine for the next 24 hours is saved in a container and stored in the refrigerator. Exactly 24 hours after the start of the procedure, the patient voids again to get any remaining urine out, and then from there the specimen is saved. The serum creatinine level is assessed at the end of the 24 hours. That 24-hour is then sent to a lab for testing. It can also be obtained from an indwelling urinary catheter if necessary. If reliable 24-hour collection is not possible, an estimate of GFR can be made using a serum creatinine value in an evidence-based equation. Several non-invasive diagnostic procedures that assess the renal system are radiography of the kidneys, ureters, and bladder, or a KUB. A KUB X-ray delineates the size, shape, and position of the kidneys. It may also detect abnormalities such as renal calculi, hydronephrosis, cysts, or tumors. A renal salt ultrasound may also be helpful in evaluating for an obstruction, which is manifested by hydronephrosis or hydroureter. Invasive diagnostic procedures could also be used for assessing the renal system, including intravenous pyelography, CTs, renal angiography, renal scanning, or renal biopsy. Quick quiz. Which intervention is most important in assessing fluid balance in the patient with AKI? That be A, daily weights, B, intake and output, C, serum creatinine, or D, estimated GFR? That answer is going to be A, daily weights. For the we're going to be looking at the potential for fluid, electrolyte, and acid imbalances, with outcomes being body weight within normal limits, clear breath sounds, vital signs within normal limits, electrolytes, and the absence of peripheral edema. And we're going to be assessing these patients very carefully. Those daily weights are going to be critical, as that's often a very early indication of fluid overload and them retaining fluid. Also, in conjunction with intake and output, monitoring that respiratory status, monitoring cardiac rhythm, blood pressure, pulses, electrolyte levels, and other institutional safety measures. Hyperkalemia is common in acute kidney injury, especially if the patient is hypercatabolic. Hyperkalemia occurs when potassium excretion is reduced as a result of the decrease in the GFR. Sudden changes in the serum potassium level can cause dysrhythmias, which could be fatal. Other alterations would include electrolytes like sodium, calcium, phosphorus, and magnesium. AKI from pre-renal conditions is usually reversible if renal perfusion is quickly restored. Therefore, early recognition and prompt treatment is going to be key. And we're going to be including within our treatment a very high focus on fluids. We want to use caution in patients with underlying cardiac diseases, though. Postrenal conditions are usually resolved with the insertion of an indwelling catheter, either transurethral or suprapubic. Occasionally, a urethral stent may have to be placed if the obstruction is caused by calculi or carcinoma. Common interventions for the patient could include drug therapy, dietary management, management of fluid and electrolyte imbalances, and renal replacement therapies, such as hemodialysis or continual renal replacement therapy. We'd also be looking at dietary management in patients with AKI. Energy expenditure in these catabolic patients with AKI is much higher than normal. Dialysis can also contribute to protein catabolism. The loss of amino acids and water-soluble vitamins in the dialysate solution used during dialysis constitutes another drain on the patient's nutritional stores. The overall goal of dietary management for AKI is the provision of adequate energy, protein, and micronutrients. Diuretic therapy in the treatment of patients with an AKI is controversial. In clinical practice, diuretics may be used to manage volume overload, although it is believed that diuretics increase renal blood flow and GFR, as well as reduce the tubular dysfunction and obstruction. Diuretics may also increase the risk of AKI from volume depletion when they're given before procedures. Dietary management in patients with AKI is going to be extremely important, as that energy expenditure is much higher. One drug you may see used a lot is going to be called Kxalate, and it reduces plasma protein levels and total body potassium content in a patient with renal dysfunction. In the past, sorbitol has been combined with sodium polystyrene sulfonate powder, or Kxalate, for administration. This use with sorbitol with Kxalate has been implicated in cases with colonic intestinal necrosis, and thus this combination is no longer recommended. Renal replacement therapy is the primary treatment for the patient with AKI. The decision to initiate renal replacement therapy is a clinical decision based on the fluid, electrolyte, and metabolic status of the patient. Renal, renal replacement therapy options include intermittent hemodialysis or continuous renal replacement dialysis, or even peritoneal dialysis. Dialysis works on two separate principles. Dialysis being defined as the separation of solutes by different diffusion through a porous or semi-permeable membrane. In the case of diffusion, this is the movement of solutes, such as urea from the patient's blood to the dialysate solution across that semi-permeable membrane. On the other side is ultrafiltration, and this is the removal of excess water from the patient. Most common reason for initiating dialysis are things like hyperkalemia, hyponatremia, hyperphosphatemia, volume overload, anuria, poisoning or intoxication, azotemia, or metabolic acidosis. An essential component of all the renal replacement therapies is adequate, easy access to the patient's bloodstream. Various types of vascular access devices are used for hemodialysis, everything from percutaneous venous catheters, AV fistulas, or AV grafts. Temporary access devices are unfortunately associated with high risk for infection, though may still be used and indicated long-term for patients that are unable to accommodate a fistula or graft. A major thing for you as the nurse is going to be making sure that you're protecting that access site, as that is the patient's kidney function. That AV fistula or graft should be auscultated for a bruit and palpated for the thrill or buzz every 8 hours. The extremity that has the fistula or graft also must never be used for drawing blood specimens, obtaining blood pressure measurements, IV therapy, or intramuscular injections. Such activities produce pressure changes within the altered vessels that could result in clotting or rupture. You also must make sure that you're quickly alerting the healthcare personnel for the absence of the fistula graft, bruit, or thrill. Remember, you're hearing the bruit and feeling the thrill. And should those be absent, it is an emergency, because the earlier you can intervene, the better chance you have of saving that access, which is potentially saving the patient's life as you're saving their kidney function. Hemodialysis consists of simply cleansing the patient's blood through a hemofilter by the use of diffusion and ultrafiltration. Water and waste products in metabolism are easily removed. This is actually a specialty I worked in for several years. It's a very unique and challenging field that while not for everybody, it can be very busy. It can also be a very rewarding specialty and career option if that's something you're looking for after graduation. On the day of dialysis, dialyzable or water-soluble medications are not given until after treatment. The dialysis nurse or pharmacist can be consulted to determine which medications to withhold or administer. Supplemental doses are also administered as ordered after dialysis. The administration of antihypertensive agents is avoided for 4 to 6 hours before treatment if possible. Doses of other medications that lower blood pressure, such as narcotic sedatives, are also reduced. Continuous renal replacement therapy, or CRRT, can be managed at the bedside of critical care nurses. It's similar to conventional intermittent hemodialysis in that a hemofilter is used. It does differ in that it provides a slower removal of solutes in water as compared to the rapid removal that occurs in the hemodialysis facility. There are four types of continuous venous to venous replacement therapies: slow continuous ultrafiltration, continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, or continuous veno-venous hemodiafiltration. CRRT is a continuous extracorporeal blood purification system managed by the bedside critical care nurse. It's similar to that conventional intermittent hemodialysis in that it does facilitate the process of ultrafiltration and diffusion. Keep in mind that critical care nurse is responsible for monitoring that patient's CRRT very carefully, as there can be many different complications that can occur during dialysis. Another method you may have heard of is peritoneal dialysis, and it's the removal of solutes and fluid by diffusion through a patient's semipermeable membrane. And this is done with a dialysate solution that's been instilled into the peritoneal cavity. The peritoneal membrane surrounds the abdominal cavity and lines the organs inside. This renal replacement therapy is not commonly used for the treatment of AKI because it has a comparatively slow ability to alter these and correct these imbalances. For nursing self-care, this is going to be it can be a very intense specialty. Making sure you're able to cope, preventing burnout, and making sure that you're really focusing on self-care, keeping yourself healthy. The healthier and better maintained you are, the better you're able to care for your patient. In the case of kidney transplantation, some of the indications will be under the age of 80, an absence of substance use disorders, and compliance with medical treatment plans, cancer-free for 2 to 5 years before the transplant, have a live donor or a cadaver donor organ ready. You will be on immunosuppressive medications for the rest of their life, and this is going to be very critical in preventing rejection. Quick quiz. The nurse expresses feeling emotionally exhausted after work with increased frequency. What strategies might be used to address potential burnout? That be A, meditation before and after work, B, seeking a new position with less stress, C, cognitive coping strategies, or D, all of the above. And that answer is going to be D. Finding those resilience interventions is going to be very personalized, and you'll have to find out what works best for you. You also want to be very aware in recognizing burnout early and finding strategies to prevent it as early as possible. Our key modifiable risk factors for AKI include anemia, hypertension, elevated cholesterol, low albumin levels, mechanical ventilation, or the administration of nephrotoxic drugs. It's also important to obtain a thorough patient history. Kidney-related symptoms provide valuable clues to assist the clinician in completing a focused assessment. But anyway, that's all we've got for this chapter. I'll see you in the next slides.